So this is a sort of review that we published 2 years ago, and for those of you who are interested, there are many other publications on this topic. You can have a look at that. First of all, I would like to discuss some easy things related to the arterial pressure curve. And the arterial pressure is the result of the ventricular ejection and the elastic and resistive characteristic of the arterial tree. And the cardiac pump generates a pulsatile, non-constant flow, and the arteries are subjected to pulsatility, and there are tubes that distribute blood flow to the organs, of course, and there are elastic structures that amortize the discontinuous cardiac ejection by storing part of the stroke volume during systole and restituting it during diastole. So all these factors contribute to the arterial pressure waveform. So this is during the systole. Then you have expansion of the main arterial vessels. And then during the diastole, you have a recovery of the elastic pressure that has been determined during the systole. So the determinants of the aortic pressure are the stroke volume, the degree of the aortic rigidity, and the reflection waves. The reflection waves are the reflection every time that we have the pulsatile curve of the pressure, which is reflected back by the elasticity of the more peripheral vessels, and especially at the bifurcation. So this is the central pressure wave you see here, the diastole, the systole, and back to the diastole again here. And in the peripheral pressure, due to the mechanism that I show you, you have an amplification of the systolic pressure and a little bit reduction in the diastolic due to the elasticity of the vessels. So in the femoral systolic arterial pressure and the pulse pressure, which is the difference between the systolic pressure and diastolic, is lower in the central compared to the peripheral. In the young, normotensive, and vasodilated, you see here, this is the central, this is the peripheral. So in the young person, when we measure the peripheral, you see that the systolic pressure is higher than the systolic pressure that you have in the center, so the real afterload, okay? If you have an older, hypertensive, vasoconstricted person, you have much less amplification, so the peripheral represent better the pressure, arterial pressure in the central. So we have different parameters, very easy parameters, which are the mean arterial pressure, the systolic pressure, the diastolic pressure, and the pulse pressure, which is the difference between the systolic and the diastolic pressure. The systolic pressure is the reflection of the left ventricular afterload with the limitation that I showed you before. So in the young person, the real afterload is lower than the pressure that you get in the peripheral. And in fact, in particularly, the systolic is representative, particularly in the elderly, hypertensive, or vasoconstricted, because as I show you, there is less refraction, and so the systolic is similar to the peripheral and the central. The mean arterial pressure, I don't want to enter here into detail here. The diastolic is very important, is a reflection of the vasomotor tone. So a depressed arterial tone should result in the low diastolic pressure. Now you have a case, okay? You have a case, a patient with a heart rate of 130 breaths per minute and arterial pressure 90/40. And then we have another patient with 70 breaths per minute and the same arterial pressure, okay? So we have 4 possibilities and 1 single choice. The arterial tone is equally depressed in A and B. The arterial tone is more depressed in A. The arterial tone is more depressed in B, and the arterial tone is normal in both cases. What do you think? Second. Do you all agree? So it's the second one, because if you increase the heart rate, you compensate, you have expected higher diastolic pressure when you have an increase in the heart rate. So if you have decreased diastolic pressure with increased heart rate, you would expect depressed peripheral tone. So take in account heart rate when you interpret the diastolic arterial pressure. Very simple. The diastolic pressure can also be low in case, of course, of low rate, because it's exactly the opposite, and in case of arterial stiffness. The diastolic pressure, we have to remember that is the driving pressure for the left ventricular coronary perfusion, is the most important, also in terms of timing. The pulse pressure, which is the difference between systolic and diastolic, is proportional to the aortic stiffness, of course. So greater is the aortic stiffness, higher is the pulse pressure, and the stroke volume. And we have to remember that if the aorta is stiff, so in case of elderly, hypertensive, diabetic patients, the pulse pressure should be larger, at least 60 millimeters of mercury, 50, I would say, 50 to 60, to assure a normal stroke volume. So if you have an old patient and the pulse pressure is less than 60, so you have 30, you can expect a low stroke volume. So it's not good to have 30 of pulse pressure in an old person, okay? So these are simple things that sometimes we don't take in account. The heart rate and the diastolic and the pulse pressure as a representative of the stroke volume without measuring directly the stroke volume. So we have interesting information about this. So this is just to be very shortly about simple information that you can get from arterial pressure. So overall, we have 3 issues that we have to consider: the preload, the flow, and the flow adequacy. And taking account all 3, then we can try to optimize the fluids, the inotropes, and vasoactive drugs. Now, we try to discuss a little bit about the fluid responsiveness, which is defined as the capacity of the heart to significantly increase the stroke volume or cardiac output in response to a volume challenge. As you know, there are different curves between relating the stroke volume and the ventricular preload. So higher is the ventricular preload, higher is the stroke volume, and at a certain point you reach a plateau. Lower is the ventricular preload, lower in stroke volume. Is defined, then we can discuss if it is true or not, but in general, that the good preload responsiveness is when you increase the ventricular preload and you have an increase in the stroke volume. When you are not responsiveness, you are expected to be on the flat part of the curve. So when you have an increase in the preload, you have not much increase in the stroke volume, okay? So this is a so-called patient fluid responsiveness. This is a patient not fluid responsiveness. So fluid infusion or whatever will increase the stroke volume only, however, if both ventricles are responsive. So in case of dishomogeneity between the right and the left, of course, this does not fit. So fluid responsiveness is equivalent to a biventricular preload responsiveness. So if you have a crosstalk because of between the two ventricles. So now I try to discuss these 10 points. So what we have learned around in this last 15 years. First of all, not every patient with acute circulatory failure is fluid responsive, okay? You see here that only with this definition, only 50% of the patients, critically ill patients, are responsive to fluid administration if we accept the definition before that fluid responsiveness is the increase in the stroke volume with the increase of the preload, okay? So only 50%. So 50% are not responsive. So that's why it's important to have more clear ideas to determine and to predict those patients who are fluid responsive, okay? So the concept here, we don't know. There is an uncertain 50%. We need some methods to better define the fluid responsiveness. Excessive fluid administration may cause harm. I see in many ICU, including sometimes hours, sometimes especially in the night, that you add 1, 2 electrolytes more, 500 milliliters, just because we have to fill in the computation in the night. But we have several studies, and this is one of them, showing that the cumulative fluid balance is an independent factor associated with mortality. And there are many studies. So more fluids we give without any need or requirement is something that seems to be associated with worse outcome. So we have to take care. 50% they don't need more fluids, and if we give more fluids inappropriately, we worsen outcome, okay? The fluid loading is an unresponsive patient may favor pulmonary edema and may decrease oxygen transport. We have seen before that the stroke volume is related to the ventricular preload, and as definition, we defined the preload unresponsiveness as those patients in which you increase the preload and you have no major changes in the stroke volume. But on the other side, you can also draw this curve, which is the relationship between the ventricular preload and the left ventricular end diastolic pressure, okay? And so when you increase the ventricular preload, you will also increase the left ventricular end diastolic pressure. So you can also say that in the unresponsive patients, so in the patient when you increase the preload and you have no increase in the stroke volume, look on the other side, you increase the preload, but you have a major increase of left ventricular end diastolic pressure, which means cardiac edema. Are you following me? So the unresponsiveness on the stroke volume is a responsiveness, negative responsiveness, on the left ventricular end diastolic pressure. And we have to remember, we were discussing with Alberto before, that we forget the formula of the oxygen transport. If we give too much fluids, we also another negative factor, not only to increase the left ventricular end diastolic pressure, but also to hemodilute the patients, because we give more fluids. And if we hemodilute these patients, we reduce the amount of hemoglobin. We have seen the lecture before that patients with hemoglobin less than 10 were associated with more difficult weaning. And I don't know if you remember yesterday, curiously, the ARISCAT score, the hemoglobin less than 10 was associated with higher risk of PPC. So there are many data that suggest that when hemoglobin is less than 10, or some anemic patient, this is associated with some complication. And we were discussing with Alberto, you know that now several randomized trials show that it's better not to have hemoglobin too high. So 7 is better than 9. Perhaps in more severe cardiac patients, we can accept 8. No? Even in cardiac surgery. This is something to think about, because we have some differences here. Many studies in association found that hemoglobin low is not good. When you do a randomized trial, you don't find the same. So there is something that is not very clear.
The problem is what to do with this patient. Should we transfuse them?
We don't know. But this randomized trial, they suggest to be very conservative, no? Even 7 overall, now it's 7.5, no, the threshold for normal patients in ICU, and 8, maximum 8.5 in cardiac patients or cardiac surgery. So restrictive better than liberal.
This is for the main transport, for the non-two procedures.
For?
This is post-op.
Post-operative, yes.
It's a pre-op.
Pre-operative is nobody knows. It's very difficult, I think, to do a study because, you know, in Italy for sure we will never do because it ethically is very difficult. But if you look at the data, we don't know. So this is, anyway, to go back to this issue that if you infuse too much without any need, we dilute and we further reduce the hemoglobin. And so in fluid non-responders, we give fluids, the cardiac output does not change because they are not fluid responsive, and we reduce the transport. So this is an additional negative issue when you give fluids without any need, okay? While in fluid responders, it's likely that you increase the cardiac output because this is the definition for fluid responsive. And so even if you have some hemodilution, this might be associated with an increase in transport. So in non-fluid responsive, if you give fluids, for sure you have a reduction in transport. In fluid responsive is the balance between the change in hemoglobin and the increase in cardiac output. Because of the 1, 2, and 3, prediction of fluid responsiveness is important, okay? Now, static measure of preload cannot reliably predict fluid responsiveness. In fact, we have not just one curve, as we discussed before, but we have different curves. For example, this is a failing heart, this is a normal heart, and between the failing heart and normal heart, we have many curves which relate the stroke volume with the ventricular preload. And what happens? That if you consider just one number of ventricular preload, you can be in two different conditions if you are changing the stroke volume ventricular preload curve in a normal or failing heart. For example, here you have this ventricular preload, and in this case you are in a position of preload responsiveness. You increase the preload and you increase the stroke volume. For the same ventricular preload, if you're in a failing heart, so in another curve here, you increase the preload, but you have not much increase in cardiac output. So for the same ventricular preload, the message here, you cannot predict if you are responsive or not, because it depends on which curve you are. So assessing the preload is not assessing the preload responsiveness. Is it clear? So static measures of preload cannot reliably predict fluid responsiveness, the static. So does the central venous pressure, for example, predict fluid responsiveness? This is a recent meta-analysis on 1,800 patients. And they found that the prediction curve, the AUC curve, was around 50, which means that predicting fluid responsiveness by using one value of central venous pressure is like to flip a coin. So you cannot use CVP as a single number to predict the preload. So you can predict preload, but this number is not associated with any prediction of fluid responsiveness. Clear? That's why, if you remember, in the Surviving Sepsis campaign in 2012, the goals during the first 6 hours of resuscitation, you see there was central venous pressure 8 to 12 millimeters of mercury. Curious for two things. First, because they included CVP there. Second, very high CVP, very high level. And we know that too much may be even associated with worse outcome. Now, this is no more valid. And in fact, you know that in the new Surviving Sepsis campaign in 2016, published in 2017, there is even no mention anymore about CVP. I think this is even too much, because we go from one side to another. But it's curious that now are even no mentioned anymore. So, we have to remember that if we substitute the stroke volume here, the left ventricular end diastolic pressure, as I showed you before, the central venous pressure, and here we put the right volume, You can see, however, that when you give volume, so you increase the right volume, so you increase the preload, and you have a no responsiveness here in the stroke volume. However, the change in CVP is quite high. That's why I would not exclude the CVP at all from the guidelines. I think that, Alberto, do you agree?
It's a good indicator.
In fact, that's my point, no? This is just being a little bit critical on this avoidance of CVP at all. So this is just to show you that we have also to consider the dynamic of CVP, not only the static of CVP. And this is something that has not been clearly investigated. And so we have to, I think, to consider that CVP is a safety parameter during a fluid challenge, in my opinion. And if an increase of CVP, for example, just to be very practical, higher than 5 millimeters of mercury, should incite to promote to me the fact that at least to stop the fluids if you increase too much CVP. So the role of dynamic changes of CVP, I think, should be better investigated, because it's in line with our clinical practice, but it's not in line with the guideline recommendation. If you take paper by paper, it's a great mess.
Yes.
It's a great mess. They include by the way, this was just to have a word in favor also of the CVP. And I think that to cancel CVP from the guidelines, like a shame now, if you measure CVP, I think it is not good. We have to rethink about CVP in the next 2 years. We will do that, of course, in Genoa, and from scientific point of view. And we are organizing for that. So actually, in most of the guidelines, you see that they suggest the dynamic parameters. What does it mean? That instead to look at fixed parameter with all the limitation that we discussed before, in order, independently of the curve that we have, you can have a look at the change in one parameter, which can be stroke volume, pulse pressure, when you have a change in ventricular preload, so going from the static to the dynamic parameters. So, and in this case, we can have two possibilities, or to use the heart-lung interaction, or to use the passive leg rising. Now we examine the heart-lung interaction. So the idea behind is that the more the cardiac output or stroke volume changes with mechanical ventilation, the more likely the patient is fluid responsiveness. So the respiratory variation of stroke volume may be used for that. And this is an example of the so famous PPV, which is, this is the artery pressure, this is the pulse pressure, as we discussed before, which is very much related to the stroke volume. And you get the maximum pressure here and the minimum pressure here. The maximum is during inspiration. Now I show you why. Because it's the opposite when you are in spontaneous ventilation. In spontaneous ventilation, you have the minimal during inspiration and the maximum during expiration. In controlled mechanical ventilation is the opposite. And you have the PP max minus PP min divided the average. This is the so-called pulse pressure variation, okay? And why that? Because here is the inspiration. During inspiration, you push all the blood here on the left atrium and left ventricle. During expiration, you get more from here. So this is why during inspiration, you increase the pulse pressure. During expiration, you decrease the pulse pressure, because you have more in the right reservoir, okay? That's the reason why you have the change in pulse pressure in inspiration and expiration. So now you have one condition here. When you have preload responsiveness, you assume that the changes in pulse pressure, so the pulse pressure variation between inspiration and expiration, are higher. Okay? When you are not responsiveness, this change is much less. Okay? Induced by mechanical ventilation. This is an example of a responder. You see a major change between pulse pressure in inspiration and expiration. In this case, it's 32%. It's very high percentage. The threshold is around 12%. When you are in a so-called normal condition, we never know what is it, but pulse pressure variation is around 5%. It's less than 12%. And many studies showed that pulse pressure variation compared to CVP or to the wedge pressure by the Schwann-Ganz catheter or the global end diastolic volume by Pico or Edwards is much more sensitive. To me, too much. Now we are trying to look at that. But anyway, now we discussed the literature available. And the threshold you see here in many studies is around 12%. So if pulse pressure variation is higher than 12%, you are fluid responsiveness. If it is less, you are not fluid responsiveness. Now there are many monitors that calculate this automatically and displayed in real time. You can also use the stroke volume variation, so you can calculate the stroke by the integration of the artery pressure, and you have something very similar. The threshold are around 13% for pulse pressure and 10% for stroke volume variation. The esophageal Doppler is another method. The question is that is during operation you can use it. We don't use frequently. We don't use, but in UK they use more often. The question is in intensive care. In post-operative you can use, but you have to use when you are able to measure the diameter of the aorta to have a real, otherwise there are some sort of internal calculation according to the anatomy which are not very precise as absolute number. It is a possibility. We are not much used to use the small one. So you see the PPV is the most related to the fluid responsiveness. Also the stroke volume, even remember the stroke volume is a little bit less because the calculation is more complex. But the other parameters you see, global end diastolic volume and CVP as a single number, are less. Now there are other methods, for example, non-invasive methods on the finger, for example, which are the plethysmographic methods. And you see here, this is coming from the oxygen saturation curve, but these methods, you see, they use different parameters that are very similar to this, but coming non-invasively from the parameters plethysmographic. I tested some of them, not very precise, even if there are some studies showing a relative good accuracy, but you see here is much, much worse than PPV. So I don't like and we don't use.
In a normal doctor that receive this is working, in the patient not.
Exactly. Even in the normal doctor, but I don't record this. I tested on myself, I had a very funny numbers on cardiac output.
Yeah.
But anyway, I don't want to discuss anything into this, just to show that these methods I don't think actually should be recommended in general practice. This is what you are referring to. This can be done. You see the threshold, at least from this study, very old studies, is again around 12%. The issue here is that we do this measurement, but it's not always easy to get the vena cava changes. But this is something that may be used, yes. So if you are able to get this measurement, and remember, you see, it seems, now we are looking, and we are doing a large program on that, but actually the threshold is always around 12%. But there is a big but. There is a big but because looks very good, everything fine, 12% threshold for everything, but there are many conditions in which you cannot apply that. For example, where if you have large irregular beats, heartbeats, and this is not clear what we mean. If you look at the papers, in many papers they excluded the arrhythmic patients. In some patients only 30% were arrhythmic, and also the level of arrhythmia was very variable. So there was no study which examined these parameters only in arrhythmic patients. Or they are excluded from the studies, or they are included in a percentage, but are not analyzed independently. First major problem to me. So in the regular beats, you don't know if this is maybe applied or not. The low tidal volume, so when tidal volume is below 8 milliliters per kilogram, does not apply. So we have to do something, otherwise this cannot be. And in spontaneous breathing, this does not apply. In other words, what we do in intensive care, we use low tidal volume. We discussed yesterday, now even in non-RDS patients, we prefer to use as much as possible spontaneous breathing, and sometimes, unfortunately, we have some patients with arrhythmia. So at the end, most of these things are difficult to be applied in clinical practice. So when PPV and SVV are not applicable, other tests might be used. And one is the end expiratory occlusion, and the other is the leg rising. Even if in most of these studies, arrhythmic patients were excluded. So it's mainly related to tidal volume, really, and spontaneous breathing. But for arrhythmia, so and so. Anyway, end expiratory occlusion. This is the theory behind this is that if you occlude the airway, at end expiration for 15 seconds, so first of all, you have not to breathe, because if you breathe, you occlude, you measure the PO1, or the inspiratory effort. This causes a transient increase in the venous return, no? Because you are occluding at the expiration, and preload is the opposite of the inspiration. So fluid responders might be identified by an increase in stroke volume or cardiac output during an end expiratory occlusion test. The problem here is that the threshold you see is 5%. So it's very, very small. So you mean that you need a very accurate measurement of stroke volume. Do you agree? Because 5% is very small, so it's not easy. And this was found in patients with low compliance and during ventilation with relatively low tidal volume, a possible substitution, but the patient has not to breathe spontaneously. And in this study, I checked this study, they included 30% of the only 30% their arrhythmia, and many of these arrhythmia was minor. So this does not mean to me that this maneuver may be applied in arrhythmic patients and in spontaneous breathing. So you see it's 5%, which is very low. Now this is a very recent study. They used end expiratory occlusion and end inspiratory occlusion, okay? This can be done when you use relatively low tidal volume. You see the low tidal volume, and you perform an inspiratory occlusion, and then expiratory, and then inspiratory occlusion. And you see here, this is the change in the velocity time by echo in this case, and they found that you have a difference in the responders, a percentage of difference in the flow of 11% and then expiratory occlusion, okay, and 3% in the non-responders. You remember that the threshold was 5%. At the inspiratory occlusion, you have a reduction of the flow of 12%. And in non-responders, 5%. If you look at the total difference, you have 23% and 8%. So you increase the threshold, okay? So you can do this maneuver at inspiration and expiration at low tidal volume, assuming that you have no spontaneous breathing and not much arrhythmias. And you see that the percentage at the end is very similar to the percentage of changing in flow when you give a fluid administration. So you can improve this at low tidal volume with two maneuvers at end occlusion and then expiration and inspiration. Is it clear? So at low tidal volume, pending that you have no spontaneous breathing and no major arrhythmias, you can occlude at end expiration, and you look at the changes in cardiac output. You occlude at end inspiration, you look at the changes in cardiac output. You sum the difference, and you have a very similar to the response in cardiac output that you can get when you give a fluid challenge. Clear? Another possibility is to change the tidal volume. Because you see that if you do that at low tidal volume, especially for pulse pressure variation, you can have a reduction in the sensibility of the use of pulse pressure variation. So it has been recently proposed that you perform a challenge of tidal volume from 1-2 minutes. You increase the tidal volume from 6 to 8, and if the change in ppv is around more than 3.4%, these patients are likely to be responsive. So you start from 6, okay? You increase the tidal volume at 8 for 1 minute. If the absolute change in ppv is more than 4%, 4-5%, means that you are fluid responsive. Imagine that you start from, I don't know if there is I have no table here. Imagine that you start from 7% of ppv, okay? Is below the threshold. But you are ventilating a low tidal volume, so you are not sure if this data is accurate or not. You change the tidal volume for 1 minute. If you have go from 7 to 12, so more than 4, 3.5, 4, you are likely to be responsive. If you change less, you are less likely to be responsive. This is another option that has been recently proposed. Not easy. Okay. The other point is that they did also with recruitment maneuver, for example, during anesthesia with the CPAP. And you see here that during recruitment there was a change in the stroke volume, and they back, and in non-responders the change was much less. So the change, this is the change induced by recruitment maneuver in stroke volume, and the change induced by fluid bolus. And you see that when you have a change in the stroke volume during the recruitment maneuver, higher is the change, reduction, higher is the responsiveness. So it's the use of recruitment maneuver to predict the fluid responsiveness. But you see that if you have a change of 20%, which is quite high with recruitment, then you expect a change in the stroke volume of fluid bolus around 5%, and so on. Here you see the PPV in non-responders and responders. By PPV, and you see here when you use the recruitment maneuver, you see a much big difference with a threshold around 30%. So if you have a change in stroke volume, or no, you have change in PPV during a recruitment maneuver, during anesthesia, more than 30%, you are very likely to predict that this patient is fluid responsiveness. But I don't like to match, due to the fact that I don't like to match recruitment maneuvers so frequently during anesthesia, and showing that anyway recruitment maneuver may be associated with reduced cardiac output. The other maneuver is the passive leg rising, which is not easy. The passive leg rising mimics the fluid challenge, but unlike the fluid challenge, there is no need of fluid infused and the effects are reversible, which is good. The hemodynamic response to leg rising can predict hemodynamic response. This can be used in patients with low tidal volume, of course, and more importantly to me, in patients with spontaneous ventilation. In patients with arrhythmia, half and half. In a patient with arrhythmia, I think we have not clear ideas. The problem is that it's not easy to do because you have to measure the cardiac output in continuous by calibrated system or non-calibrated system, but better calibrated system. You have to put the patient in this position, and then you can see the change in cardiac output, and you have to be sure that when you go back to the position, sitting position, you reach the same cardiac output. So it's not easy maneuver. We don't use it very often. And the other point, of course, the patient has not to have very high intra-abdominal pressure, which is another factor confounding the response, and also not increase the intracranial pressure and so on, and cardiac failure. Anyway, several studies show that the threshold is around 10%, so the responsive is when you perform the leg rising and you have an increase in cardiac output of 10%, more than 10%, these patients are likely to be fluid responsiveness. And this seems to be very effective, you see here, in spontaneous rebreathing. So to conclude here, I think that if you have all the possible perfect patients, you can use the PPV, or stroke volume variation. But if you have low tidal volume, one possibility is to use the end expiratory occlusion maneuver, but better to use the end inspiratory and then expiratory at low tidal volume, or to increase the tidal volume, okay? If you have spontaneous breathing, the only chance that you have is to do the leg rising. If you have arrhythmia, you are in trouble. This, I think, to summarize briefly all these very complicated issues. So, protocols using dynamic tests are associated with improved outcome. There are not many studies. This is a recent meta-analysis showing that incorporating dynamic assessment of fluid, it seems to be associated with better outcomes, but of course these are very different studies with very few patients, as you can see here, and so I think this has to be proved in the next future, but this is a recent study. last two slides, the decision to start a fluid administration should not include only these parameters, but the presence of hemodynamic instability and peripheral hypoperfusion, which means motor screen, hypotension, oliguria, or hyperlactatemia higher than 2, according to the recent guidelines, and the presence of fluid response. So only the presence of fluid responsiveness, as we discussed with Alberto yesterday, I don't think is the only parameter to be considered. This has to be associated with some clinical reasons to do that. And of course, we have to be in account that the patient has to be a limited risk for excessive fluid overload. So if you have a RDS patient with alveolar capillary leak, you have to consider that. So the decision to start fluid administration, remember, is these parameters with all the difficulties that we discussed, and the presence of hemodynamic instability, so clinical parameters. The decision to stop administration is the disappearance of hemodynamic instability and peripheral hyperperfusion, including lactate, so the metabolic, or the presence of preload unresponsiveness, so it's no more and, or height risk of fluid overload in severe hypoxemic patients. So I think we should balance the decision to start to be extremely cautiously, and the decision to stop, if you have the disappearance of this, independently from the preload unresponsiveness, might be a guideline, a guide to stop the treatment. Okay? So to conclude, we have acute circulatory failure. We have to detect, of course, if you have evident fluid loss or very early phase of sepsis, perhaps we have to give some fluids, of course. If you are losing fluids, we have to give fluids. If no, we have to look if you have spontaneous breathing, cardiac arrhythmias, and eventually low tidal volume and low compliance, so RDS. If it is no, we can use different tests, but we have seen that pulse pressure or stroke volume variation may be very helpful. Of course, other fluids, other techniques, but this, I think, may be extremely helpful in these patients. Don't consider the mini fluid challenge that was proposed with colloids, and now we have not to do anymore. If yes, I think it would not be so simple as here, because I showed you that if you have cardiac arrhythmias, yes, perhaps the passive leg raising test might be applied for arrhythmias, but in the study only 30% they had arrhythmias and not severe, so it's something to be further evaluated for arrhythmias. If you have low tidal volume, I showed you that you can use the end respiratory occlusion, but the percentage of threshold is very low, so you should use at end inspiration and expiration, or to increase briefly the tidal volume. Okay? Is it clear? If you have spontaneous breathing, I think that, of course, the end respiratory occlusion for 15 seconds is not possible. And so it's very likely that the passive leg resizing is the only option, if possible, to be used. So this is, I think, is the summary. So this is, I try to summarize, with this point, I think, the most updated knowledge about hemodynamic monitoring in critically ill patients. Thank you.